Hi friends, this is Dr. Kannan from Plexus Ortho. Today we're going to discuss an X-ray which is very commonly asked in both your OSCE and Viva OSCE exams. We're going to make a very short video about scaphoid fracture, non-union and its consequences. So they may usually give you a picture of a 35-year-old male patient, 35-year-old male patient with pain in his wrist with an injury of 3 to 4 months old, a trivial injury. So you should always palpate the scaphoid tubercle and check for tenderness. So what are the three very specific and sensitive points for scaphoid non-union or scaphoid fracture? One is tubercle, scaphoid tubercle tenderness, number one, right? And number two is is the grind test. Pressing on the thumb causing pain in the base of the scaphoid is called as a grind test. That is pressing on the thumb. This is also positive. And you also have what is called as a snuff box tenderness. So all of you know the snuff box. We have discussed this in another video. Please take a look at it. So snuff box tenderness also is seen in. So a combination of these three, 2 out of 3 are positive, then there is a strong suspicion for scaphoid fracture. So here we can clearly see the X-ray. This X-ray is showing a fracture of the scaphoid, right? And there is a gap of about 1 to 2 millimeter in the waist of the scaphoid. Probably this is more proximal, slightly more proximal than we would like, but this is a non-union. There is a gap present for about 1 or 2 millimeters, right? There are some cystic changes which is not very obvious, but the established fact is that this is probably a waist scaphoid non-union, right? So they may ask further questions regarding the blood supply of the scaphoid. Let's go over a few of these important points regarding the scaphoid. So this is the radius from the lateral profile. This is the scaphoid, right? And this is the volar side and the dorsal side. All of us know the blood supply mostly comes, 80% of the blood supply comes from the dorsal radial carpal artery branch to it enters the scaphoid in a non-articular ridge, dorsal ridge, and it supplies 80% of the scaphoid. Another small twig is given off from the volar radial artery, which supplies about 20% of the scaphoid. So there are two blood supplies. One is a dorsal branch which enters the dorsal non-articular ridge and supplies about 80% of the scaphoid. The second one is the volar radial artery branch, which supplies about 20% of the scaphoid. Because of this retrograde flow in the scaphoid, so therefore the flow in the scaphoid is retrograde. It starts retrograde and goes antigrade. Because of this, there is good blood supply in the distal portions of the scaphoid, and as we go more and more proximal, the blood supply becomes less and less. So the blood supply is very good here, the blood supply is very good here, it's good here, but in this area it is very poor. So therefore there is a higher chance of avascular necrosis or poor because of poor blood supply. There is a death of the bone tissue in this area, and again because of the same reason, there is a higher chance of union in the more distal portions, lesser chance of union in the more proximal portions. So therefore proximal pole fractures are more prone for non-union, whereas tubercle or distal pole fractures are less prone for non-union. This is a very important concept that you have to keep in mind when describing scaphoid fractures, right? Then what are the other things that we have to know of? Let us go ahead with classification of the scaphoid non-unions. Scaphoid non-unions can be included in the classification of Herbert's system. Herbert's classification. This is not great for scaphoid non-union, but you do have to describe this in your exams, unfortunately. The second way to describe these fractures are stable or unstable non-unions. Stable non-unions are length stable, that is not collapsed, that the length of the scaphoid is maintained. And unstable non-unions is where there is a humpback deformity or the humpback deformity where there is a significant loss of bone and ligamentous tissue may be also injured, causing a humpback angle, change in the angle. So next let us go to the what is called as what are the treatment options available. So the patient has presented to us 3.5 months after the injury, and there is a gap in the scaphoid fracture, and here the only treatment available is a stable fixation of the fracture, with bone graft. Now, why would you want any other investigation? Yes, we may take what is called as a CT scan. Why would we need a CT scan? To see the deformity, cystic changes in the scaphoid, and any deformity like humpback deformity in the deformity which is seen in the scaphoid, because the treatment will change, or we will need a bigger bone graft to fix this. Second investigation that we would require is called the MRI scan. MRI scan would be required to look for the vascularity of the, just as we discussed, the circulation is dorsal to and dorsal distal to proximal, and therefore there is a good chance that the vascularity of the proximal pole may be disrupted. So therefore we have to get an MRI scan to make sure that the proximal pole is vascular. Next, if the proximal pole is avascular, and what do you do if it is vascular, right? So if the vascularity is maintained, or if it is a avascular necrosis. In case of avascular necrosis, we need to use what is called as a vascularized bone graft. So this vascularized bone graft can be a pedicled bone graft. That means we do not disrupt the blood supply. We use the blood supply with the bone and swing the bone piece from the distal radius and fix it with a Herbert screw or K wires. Or it can be a free vascularized graft. What are the free vascularized graft options available? We can use the medial femoral condyle, which is based on the descending genicular femoral artery branch. So we can use a free vascularized graft or a pedicle graft. So pedicle graft, all of you know, is the one. What is available is a 1-2 ICSRA, or 1-2 intercompartmental supraretinacular artery flap can be used. We can also use the pronator quadratus pedicle flap, pherecal flap. So these are the 2-3 options that are available for pedicle flaps, and we can use a medial femoral condyle flap bone graft for a free vascularized bone graft. If it is a vascularity is intact, if the proximal pole's vascularity is intact, then we have to do what is called as, we can use a free bone graft, which could be iliac crest bone graft. And then we can use distal radius bone graft, which is the most commonly used one. Iliac crest when we require tricortical bone graft in cases of humpback deformity. In case of humpback deformity, you can use tricortical graft. Distal radius graft and or olecranon can also be used as a source of the bone graft. So these are the options available. So if the proximal pole or the proximal piece of the scaphoid is avascular, then we use what is called as vascularized bone graft. It could be pedicled or free vascularized. That is, you'll have to do microvascular anastomosis. You take a piece of bone from the medial femoral condyle along with its blood supply, and you have to attach and give a new blood supply at the level of the wrist, and that is called as a free vascularized bone graft, which requires microvascular expertise. Then we can also, if the vascularity of the proximal pole is intact, we can use free or normal bone graft, which is for example like iliac crest, distal radius, which is used most commonly. Olecranon also can be used. Iliac crest graft is preferably used when you need a tricortical graft to correct the humpback deformity. So let us look at how you would graft this. So this is the scaphoid fracture. You have to prepare the ends, right? And you would find a gap of whatever measurement. You have to fill it up. With bone graft, and usually the preferred mode of fixation for compression is a Herbert screw or a headless compression screw. So we will discuss about headless compression screw in a different video. This is called as a headless compression screw, right? Also many authors or surgeons use K wires as well. You can use multiple K wires, right? The important thing about scaphoid non-union fixation is rigid fixation and protection with biological preparation of the graft site, right? So these are some points about scaphoid non-union based on this X-ray that we are seeing here. I hope this clears some of your doubts, right? So when you look at this X-ray, you must immediately realize that this is a scaphoid fracture, probably in the waist, right? And it is a non-union. Straight away you should call it a non-union, right? Once it is a non-union, you would require to fix it. It is not going to heal on its own. What is the natural history of a scaphoid non-union? It is called as a scaphoid non-union advanced collapse wrist or a snack wrist. What is a snack wrist? Because of the consequences of a scaphoid non-union, the wrist progressively becomes arthritic, and there are various stages of snack wrist which we will discuss again in another video. So, and over a period of time, all the joints or the surfaces of the wrist become arthritic. The last joint area that becomes arthritic is the radiolunate surface, which becomes arthritic at the end. So this is the scaphoid non-union advanced collapse. Right, I hope this gives you a brief idea about scaphoid fractures and how to answer these questions both in your OSCE, Viva OC and your theory exams. This is Dr. Kanan Kumar from Plexus Ortho. Thank you very much for hearing me out. Thank you.